Hello, ladies and gentlemen. I'm proud and honored to present this and share this session. We have outstanding speakers. We will deal with the topic of devices for the treatment of heart failure. We really have top-line speakers here, and I thank Edwards Therapeutics for their support, unrestricted support to this session. So it is now my pleasure to introduce the first presentation by Andrew Coats, Professor Coats, and he will outline what it is new regarding the indication to treatment of mitral regurgitation in the patients with heart failure. Andrew.
Thank you, Marco. Great pleasure. And it's great to be together with you and Fabien. We've been involved with getting together a position paper that involved 4 associations of the ESC in one paper. It did take a very long time, but I think it's been a very valuable exercise. And I thank you both for your assistance with that. So if I could have the next slide.
So maybe, Andrew, I can take over here. So the first step we want to show you in this session is the update of the American guideline. And we will focus on first mitral regurgitation and then on tricuspid regurgitation in the second step, because there are some news here we would like to show you. So regarding secondary mitral regurgitation, which is probably the most interesting topic in that context, we welcome a new recommendation for transcatheter edge-to-edge repair, which is a 2A recommendation that has been limited by the American guidelines to the Coop population. And this population has been defined in a very pragmatic way with a left ventricular function of 20 to 50%, matching the inclusion criteria of the study, a left ventricular and systolic diameter of less or equal to 70 millimeter, which was also an inclusion criteria in the study, and the pulmonary artery pressure, systolic pulmonary artery pressure of less or equal to 70 millimeter of mercury. If we look at primary mitral regurgitation, then there has been an upgrade of transcatheter edge-to-edge repair in severely symptomatic patient, meaning patient with an NYHA class of 3 or 4, and favorable anatomy. That's also an important point. To a 2A recommendation, there was previously a 2B recommendation. If we look at surgery is as a 2B recommendation for ventricular secondary MR. You can notice that it's a lower recommendation at transcatheter edge-to-edge repair due to the results of the Coop trial. And then there is a new entity, which is atrial secondary mitral regurgitation. You know that we don't know exactly in that patient with annular dilatation, which is the best treatment. And there is a 2B recommendation for surgery in that patient. And the last new recommendation, which is an important one, I think, as well, is for the treatment of patients with multivalvular DC that are also heart failure patients. And in low-risk patient, the recommendation is surgery. And in high-risk patient, we have now a recommendation for stage, transcatheter aortic valve implantation, and transcatheter edge-to-edge repair. So that's a bit an overview of new recommendation regarding MR in the American guidelines. So now, Andrew, I think you will present the European position paper.
Excellent. Thank you very much, Fabien, for giving us that great introduction on what's happening the other side of the Atlantic. Next slide, please. So as I mentioned, we worked, and it took some while to get 4 associations from ESC, the Heart Failure Association, Cardiovascular Imaging, EHRA, Percutaneous Cardiovascular Intervention, in a joint position paper that Marco published in his journal. It was in European Heart Journal, Marco. We didn't give that one to you. Apologies. So it's the management of secondary MR in patients with heart failure. And the important central part of this, I think, shown on the figure on the right, in that is we felt it's essential to have a multidisciplinary team approach to the management of secondary MR and heart failure, because there are simply too many things happening in these patients. We have to adequately assess guideline-directed medical therapy at multiple points in the patient journey to ensure that they are optimized, because we've seen from, as we'll see later, the disparate results of two important studies, that the background medical therapy and the ongoing optimization is critical to evaluate the true role and success of intervening on the mitral valve. There's also an overlap between guideline-directed medical therapy optimization, the appropriate use of CRT, the appropriate selection of patients and choice of procedures for transcatheter interventions, and also the role of surgery, which is critical in many of our patients, and that can only be assessed when the whole team is present. It also, very importantly, involves considerable input from experts in imaging for the correct imaging technologies, for the correct quantification, to make sure we're not either intervening too early or too late. Next slide. So an important part of this is a decision algorithm tree, and it starts off with a fairly simple clinical observation, which is symptomatic heart failure with moderate or severe mitral regurgitation. Now, many people might have felt, okay, maybe there should be a recommendation to how to manage MR, but it's far more complicated than that. So if you look at the decision points in any analysis for an individual patient, which should be done by the team, first of all, the team needs to have the case presented at an early stage, well before people feel that an intervention is essential, really in the lead up to it, to know what the options are. So first of all, guideline-directed medical therapy and CRT should be optimized, and it's rare to have everything absolutely perfect. We know that. People aren't on adequate doses. Sometimes things have changed, and sometimes people have overlooked an intervention. And indeed, as we saw at this meeting yesterday presented by Marco Metra, there is major new advances in what is recommended in guidelines. We had that wonderful peak look yesterday. So there are some patients who, honestly, with review, we feel they are towards the end of their life, and it would be inappropriate to put them through the risk and trauma of a major intervention. And that's quite appropriate. There is a management for palliative care and end-of-life care. We also might identify significant coronary disease, which is an important etiology of heart failure, and that requires consideration of treatment. That may well be surgery if the surgical risk is modest and can be well compassed by the potential benefits. And if that's the case, in the presence of that significant MR, then they can have surgical correction at the time of the coronary artery surgery. If, however, the surgical risk is too high, then there's alternative of percutaneous intervention on coronary disease. But then there will be some patients, even with coronary correction, where there's persistent symptoms and residual severe secondary MR. And they're the people we consider new possible interventions for benefit. So the first question, is there end-stage RV or LV failure that makes it impossible to consider an acceptable risk that we can improve the condition? If that's the case, there are alternatives, mechanical circulatory support or transplantation. However, if the LV and RV failure can be managed and is still significant, moderate, severe MR, then we should go ahead and consider other options such as transcatheter mitral edge-to-edge repair, but it's only in selected patients that requires fairly detailed imaging analysis and observations of the implications of the MR. Next slide. So what we most consider is patients should satisfy the COAP criteria, because as we know, there are two major trials, the COAP trial that had a very positive effect on composite endpoints at an early stage, very powerful, up to 50% reduction. But an apparently similar group of patients with the same intervention, MITRA-FR, did not get such a benefit. And the difference was subtle differences, a combination of differences in the inclusion-exclusion criteria. And the difference was the COAP patients had more severe MR, but less dilated ventricles. So the COAP criteria are our guideposts for patients who we believe have a better chance of responding positively to this intervention. So the Coop criteria are secondary MR grades 3+ or 4+, graded by one of three criteria. And as Fabien has mentioned, ejection fraction in the range of 20 to 50%, and a ventricle is not too enlarged in systolic dimension equal to or less than 70 millimeters of mercury. We have exclusion criteria based on pulmonary artery pressures above 70 or severe RV dysfunction. And then the three possible measures are the effective regurgent orative area greater than or equal to 0.3 or PV systolic flow reversal. If the EROA is between 0.2 and 0.29, you require one of the following: regurgitant volume greater than 45 mils per beat, regurgitant fraction greater than or equal to 40%, or vena contracta width greater than or equal to 5 millimeters. And then if the ERO is less than 0.2 or not measured, then you require two of those criteria, including also peak E wave velocity 150 centimeters, PISA radius greater than 9, and a large greater than 6 millimeter hollow systolic jet wrapping around the left atrium. So it looks a little complicated, but it's a good memory stick to assess the patient and say, do we believe that they would have been eligible for the COAP trial? And of course, that involves guideline-directed medical therapy optimization. And if the answer to that is yes, and the rest of the team evaluation with adequate imaging, consideration of alternatives, then we do recommend in these position paper to use the transcatheter edge-to-edge repair methodology. Next slide. So now I will hand back to you, Marco, because this is an important paper from your group, looking at this same issue from the point of a sort of registry evaluation of patients.
Thank you, Andrew. And yes, I'm proud, honored to present this paper that came from our group, from Mariana Damo, first author, and she gathered together actually three different groups in Europe. And this is real world experience and data applying the COAPT-like criteria. And what this study clearly shows is that the fulfillment of the COAPT-like criteria by the patients is associated with a better outcome, reduced mortality, compared to performance of a mitral clip procedure in patients who do not have the COAPT-like criteria. A further analysis that we did in these patients and is published also subdivided the COAPT criteria. So we had unstable heart failure symptoms. That means essentially New York Heart Class 3 to 4 symptoms. We have a low ejection fraction, so severe left ventricular dysfunction, and we have a right ventricular dysfunction. And it is interesting to see that whereas left ventricular dysfunction had a role for the long-term outcome, the earlier impact on the outcome was that of right ventricular dysfunction. And I think it is important to point out this because right ventricular dysfunction actually was not assessed in mitral FR and probably is a major reason for lack of success of the mitral clip procedure. Next slide just compares from the same study the patients in our study cohort with those in the COAPT trial with respect of the mortality data. And again, our study had data which were very similar, if not superimposable, to those of COAPT. So, I mean, in real practice, we may have the COAPT and apply the COAPT-like criteria. And now I let to Nicole Praz to continue, to Fabien Praz to continue. I think.
Maybe just one question to you, Marco and Andrew, regarding what has been presented. So, the statement paper as well. Would you agree to say that if we follow the Coop criteria, as you showed also very elegantly in your study, we will probably identify patients that will benefit from a prognostic way from edge-to-edge repair? But would you say also that, of course, having optimization of medical treatment as well, there are a collective of patients, a population of patients that could have a benefit, a symptomatic benefit that will maybe not translate into a prognostic benefit long term. Is that something you would consider as well for the treatment of your heart failure patients?
Andrew, do you want to?
Yes, no, I'll do that. I think it's absolutely essential. In heart failure, we've been spoiled for choice, and we have drugs that we know reduce mortality, but we've rather taken our eye off the ball of the important aspect of symptomatic deterioration. And if we can offer, with preservation of good prognosis and potentially, as you mentioned, additive value, we can also improve symptoms. That's a very valuable endpoint. But I'd also like to ask Marco, he presented very nicely, almost like an evaluation that Coop seemed to get it right with their criteria, because in his practice, the patients who would have satisfied Coop criteria did far better. What percentage of the patients who you might consider for this procedure end up satisfying the Coop criteria? Is it in your practice a half, a quarter, a third? Is it more selected than that? Can you give us a sense of the pipeline of patients we might need to evaluate?
Okay, good questions. First of all, we know that Coop took a very long time for enrollment, with a mean number of patients which was low for each center. And but the accurate selection saved the procedure, because I still remember when Coop came out after the Mitral FR data were presented. Would have been very difficult to save the procedure otherwise. So appropriate patient selection is mandatory if you want to have an effect on the outcomes. In our experience now, the majority of the patients fulfill the Coop-like criteria. But we still remain with a large number of patients, as Fabien was pointed out, that do not fulfill the Coop criteria. On the other hand, mitral regurgitation causes an increase in pulmonary pressures, and it's difficult for me to think that it should not have an impact on the symptoms of the patients. Regretfully, symptoms were not assessed in many registries with a mitral clip, and we have been, and in general, in heart failure, and Professor Coats knows very well, we are too much focused on outcomes, hospitalizations, and mortality, whereas symptoms play a major role. So I think there is room for an indication, and I cannot predict. I cannot talk about the ESC guidelines, unfortunately, but because of the agreement with the ESC. But I think there is room for an indication for percutaneous treatment of mitral regurgitation, as well as other procedures to improve symptoms, even if they may not be effective on remodeling and on outcome. But symptoms are still very important, and for most of the patients, and actually many patients ask, they prefer, they trade off a few months of survival to have an improvement in symptoms. So
just before we move on, you raised an important point about the fact that it's not every patient that's suitable. We do have another trial coming, RESAPE-HF2, that appears to be presenting a slightly less severely affected patient. So we may get further information of extending the indication for repair in this regard in future. But we need to wait for that.
It will take a bit time, but I think it could give some additional answer on that population. So maybe I can continue here, because Marco, you show very elegantly that one of the most important difference between the trial was maybe the assessment of right ventricular function, and we know in our heart failure patient that it's a key also for the determination of prognosis. And if we look now at the right side a little bit, we also have tricuspid regurgitation, and maybe I can show you if we go to the next slide where again the new recommendation, the new American recommendation regarding tricuspid regurgitation. Can we go to the next slide, please? So that's again the same table, and you see here the new recommendation regarding the treatment of isolated secondary tricuspid regurgitation first. That was defined also as severely symptomatic, that meaning in patient with class 3, NYHA class 3 or 4. In that population of patients, there is now a recommendation for surgery, which is a 2A recommendation. And then if we look at primary tricuspid regurgitation, isolated or during left-sided surgery, there was always actually a 2A recommendation that has not been changed. What we don't have in the American guidelines yet, because probably of the lack of evidence as well, is the implementation of transcatheter treatment for tricuspid regurgitation, which is, as you know, an emerging technique that is performed in more and more patients, also patients with heart failure, and that could have some potential for the future. I show you on the next slide, and we can then discuss, because I think that's a very interesting topic as well. On the next slide, I show you a proposal we have made regarding selection of this patient. And of course, all this is not evidence-based so far, but a bit in analogy in what Andrew showed regarding secondary MR. We imagine an algorithm to select this patient having severe secondary tricuspid regurgitation. And again, I think symptomatic treatment with medical treatment is absolutely key again in that population of patients. The evidence is of course much less for the mitral, for secondary mitral regurgitation, and we have some data to acquire there, I think. But if the patient are still symptomatic despite an optimized medical treatment, then we should probably consider an intervention that could be surgery in low-risk patients, but most of these patients are not low risk because of comorbidities. And then we propose to look also at the pulmonary hypertension. And if it is more than 70 millimeter of mercury, this patient has been excluded from most of the study, Triluminate and other study looking at this. And we don't know exactly what will be the benefit of that patient, and maybe a dedicated treatment of pulmonary hypertension may be more appropriate. And then we have to go, so that was a bit of a clinical judgment and clinical parameter, and then we have to go into the anatomy of this patient. And patient with predominantly annular dilatation may benefit from an annuloplasty, reducing the dimension of the right ventricle. Patient with a pacemaker or patient with anteroseptal with some particular anatomy of tricuspid regurgitation would be more appropriate for edge-to-edge repair. You know that there is some dedicated device, TriClip, for example, or Pascal for the treatment of TEER patient. And what is coming as well in patients with maybe more advanced disease is also open valve replacement. That is a very powerful treatment, transcatheter valve replacement, and has a lot of potential for the future. So maybe we can briefly discuss, Marco and Andrew, how you see the role of this treatment of TEER, could be surgery or transcatheter for heart failure patient.
Well, I might start, but I'll ask Marco with his experience. But certainly the preference of the heart failure physician is to avoid major surgery if possible. And we would very much favor a percutaneous procedure. It doesn't exclude future options. The sort of exposure risk of the patient to just have a strong feeling is much easier to control. And we believe the tricuspid valve, there'll be many, many cases where it's a cause of major disabling symptoms. And so we're really excited by the potential of percutaneous intervention. Whether we're going to get a mortality benefit by tricuspid intervention, I'm not so certain. It may require a much larger trial to do. And maybe surgery might have a role there. But I certainly, my preference would be the further improvement of transcatheter procedures and experience, the correct selection of patients. And there I see real potential there. But Marco, in your experience, is this common, and are you tempted to start trying out this intervention at the moment?
Yeah, thank you very much. First of all, let me point out that I'm relatively old. And I grew up with the concept of afterload mismatch. We were concerned so much with the afterload mismatch. And this is a major difference with surgery and with the substitution. I'm talking about the mitral valve again. But mitral clip mitral clip is generally very well tolerated, also in patients with severe left ventricular dysfunction. And this may not be the case when we change the valve and put a new valve. So also when considering surgery as an alternative to percutaneous procedures, and I fully agree with Andrew that we are more strongly in favor of percutaneous procedure, there is a rationale for this, is that the afterload mismatch that you create with the percutaneous procedure will never be as much as when you put a new prosthesis in the patient. And this applies as well to tricuspid. I think, I like the concept of the tricuspid valve. I know that from the interventional cardiologist, it's much more complicated than the mitral clip working on the tricuspid valve. We are going to have a patient now done in Brescia by Mariana Adamo. It's complicated, but it's more complicated, but it's again, if we think about symptoms, if we think about the role that central venous pressure has on renal dysfunction, hepatic dysfunction, gut function, so the tricuspid valve, it's a systemic valve. It has an effect on the systemic venous system. And so there are many good reasons to think that the correction of tricuspid regurgitation may have a benefit on symptoms, on treatment of the patients. And in many cases, this may well go beyond a benefit on mortality. So we have to, and Andrew Coats is president of the Heart Failure Association and has a major role from this point of view. We must move away from this mortality-centered approach. Of course, with new drugs, there is the issue of safety of the drugs, but the benefit on symptoms is something that must be highlighted and put forward for the benefits of the patients.
I agree, Marco. I think you mentioned again a very important point about right ventricular function. Actually, again, I think we talk again about right ventricular function, and I think in this patient it's also something absolutely key, because we see, as you mentioned, in some replacement, we see already with replacement of the tricuspid valve that there is some complication in terms of failure of the right ventricle. And the problem is that we don't know exactly how to measure the right ventricular function. We don't have good tool for that, and usually it's quite difficult to predict which patient will have some additional symptoms or even some failure after replacement. So a lot of to learn in that direction as well. Maybe one last question that I'm wondering a little bit: what would be actually which new avenue you see in terms of medical treatment for patients with tricuspid regurgitation? Is there something new that you can foresee that can help this patient as well?
Good questions, but we are tied to diuretics. They think maybe a better use of diuretics, but it's a major problem. And patients with tricuspid regurgitation develop cardiorenal syndrome and renal kidney failure. May I ask to you very practical the role of the systolic pulmonary pressure, because you put the cutoff of 60, if I understand, but it can easily move to 50 or to 65, and treatment may have a major role. So how much is it important?
So the patients that has been excluded from the study are 70. We look at the pulmonary pressure, and most of the time, we cannot really measure it because of this very severe tricuspid regurgitation. So we are underestimating this. We try to look, to do right heart catheterization in that patient and to look at the resistance as well, to give us a little bit an idea what is actually the pulmonary resistance, and are we not underestimated actually the pulmonary pressure. And in some patients, we refer this patient also to dedicated treatment of pulmonary hypertension prior to tricuspid intervention, exactly in order to prevent actually right ventricular failure if we are successful in treating a TEER. But honestly, we don't know. There is not a cutoff. We don't know if this patient benefit or not because they are not the population of the study. And I think it's still too early to give a clear cutoff. But a very important point is to be aware that you underestimate the pulmonary pressure in the presence of very severe tricuspid regurgitation.
Okay, so I don't know if I have to conclude. I think it has been a very important session. Unfortunately, we could not present the data from the ESC guidelines because there is an embargo until the end of August at the ESC Congress. But Fabien Praz was able to say something regarding the American indications. I may predict that we are going to align very well. And I wish to thank all of the speakers. I wish to thank Andrew Coats because without his commitment, the consensus document, also the consensus document by all the different working groups and associations within ESC, I wouldn't have been possible. It took years, and it just took the things from the start and could accomplish it. So, I mean, the scientific community has to be grateful to him. And I don't know if somebody wants to say other final words, but I think that this topic of treatment of valvular heart disease is one of the most actual things in heart failure treatment.
I totally agree. We owe it to our patients to do better. Valvular heart disease and heart failure was a big topic in the 50s and 60s, and we've taken our eye off the ball for too long, and it's now back center stage.
Great.
Thank you. Thank you, Marco and Andrew. Very nice session. Have a good day.
Excellent.